Okay, that's terrific. All right. Well, we're going to go ahead and get started. So we've got an intimate group here this morning, but welcome. My name is Sarah Klein. I'm the CEO of the Epilepsy Foundation of Colorado and Wyoming, and delighted to welcome you to our annual Epilepsy Connect Symposium. This session is the first of our CME accredited sessions. So if you are looking for continuing medical education, you're in the right place, but obviously it's open to everyone. So we're thrilled to have you. Before I introduce our speaker, I just want to say thank you to our sponsors who have made today's session possible. Our gold sponsors are Charlotte's Web, Jazz Pharmaceuticals, Pharma, and SK Life Science. So a big thank you to them. Now, happy to introduce our presenter this morning, who is Dr. Matthew Mian. Dr. Mian attended Duke University for undergraduate and completed his MD degree at Harvard Medical School. He did his residency in neurological surgery at the Massachusetts General Hospital and completed a fellowship with a focus on stereotactic and functional neurosurgery at Emory University. So he's an underachiever. We're not impressed with him at all, but you know, we take what we can get. Dr. Mian is currently the director of functional neurosurgery at Swedish Medical Center. And before this, he was a neurosurgeon at CarePoint Neurosurgery and Spine. Dr. Mian also serves on the professional advisory board of the Epilepsy Foundation, so we're really grateful to benefit from his leadership and expertise on a regular and ongoing basis. So, Dr. Mian, thank you for being here.
Thank you, Sarah. And thank you, everybody, for coming. So I'm a surgeon here in Denver that specializes in epilepsy. And what I want to do this morning is kind of review the state of the art of epilepsy surgery today in 2023. Hopefully make it accessible to both clinicians and non-clinicians. So I have no disclosures related to today's talk. I think Sarah kind of went over this already. So just by way of background, probably don't need to tell this audience, but drug-resistant epilepsy is a huge problem. We think that about 30 to 40% of patients with epilepsy can't find satisfactory seizure control with drugs. And that's historically the cohort that we focused on for surgery. We call anyone's seizures that persist despite 2 or 3 drugs to be medically refractory or drug resistant. And we know from previous studies, I think we have one here, that for those patients, that subset of patients, the chance of finding seizure freedom with a 4th, a 5th, a 6th drug is unfortunately quite low. And this number really hasn't budged over several decades, despite considerable drug development. And so this is the population we're focusing on. We know that untreated drug-resistant epilepsy has a huge impact on a person's life, difficulty maintaining employment, changes in cognition, quality of life, and then, of course, the catastrophic thing that we worry about, which is sudden death or SUDEP. And so strong motivation to treat these patients. I think the most common question I get, and the one I struggle with the most, because I think the answer is pretty straightforward, is who should we think about surgery for? Who would be a candidate for surgery? And I think the mandate is actually pretty broad. Most of us would say that you should consider surgery for any patient that continues to have seizures that impact his or her life after trying 2 or 3 drugs. Now, the number of seizures, the frequency of seizures, we know can be very different between patients, and they can judge them to have a different impact on their life. But the data support that these are the patients that are helped with epilepsy surgery. What are the benefits of surgery? And there's a whole slew of surgeries, and we're going to go through them. But certainly in some cases, surgery can be curative. It can render patients seizure-free. But even when it's not, all of the procedures we'll discuss today have good clinical trial data that suggests they improve quality of life. We can reduce medication needs, and either through reducing medications or through reducing seizures, we can see that patients have improvements in cognition and thinking and memory. And I'd say that the technology we have today is improving rapidly. And I'm going to go through some of the newer procedures that we have. A lot of these are less invasive, less cumbersome, less difficult for the patient than even what we had just 5 years ago. And so things are actively changing. In terms of gaps in epilepsy care, I think we all recognize that epilepsy is a fairly common disorder. 1 in 26 people in their lifetime. There's, at any given time, probably even more than that, more than 1 million patients in the United States with epilepsy. And yet the number of procedures that we do versus the number of patients that would be candidates is unfortunately quite small. And so that's what we're trying to change with educational sessions like this one. In general, what's our strategy? I mean, how do we think about epilepsy surgery? In most cases, it kind of follows this algorithm. So we're first just trying to understand where in the brain these seizures are starting. And we next ask whether the tissue where the seizures are originating is essential for normal function. Is it what we call eloquent? If it's not, we may have an opportunity to remove it, to burn it with a laser. If it is, or we're concerned about the safety of that region, we might use a different set of techniques that we collectively refer to as neuromodulation to try to change the seizure network. A distinction that's probably familiar to most people in this room, but I'll go over quickly, is that between partial onset or focal epilepsy and generalized epilepsy. Partial onset epilepsy really is typically a situation where seizures start in one or maybe more than one spot and then spread from there. I kind of liken seizures to wildfires that start and then spread. Generalized epilepsy is quite different. This is often congenital, and the seizures start all over the brain at once. So the strategies we employ for these two kinds of epilepsy are different. Most adults, I treat primarily adults. Most adults have partial onset epilepsy, and most of the surgical tools we'll discuss today, with some exceptions, are for partial onset epilepsy. But I think very exciting, this is changing. And so I'm going to talk a little bit about what's on the horizon and what's even being done now for patients with generalized epilepsy. So in terms of our approach, as I said, the first thing we try to do is localize, figure out where in the brain these seizures are coming from. How do we do that? We use a variety of tools: the seizure symptoms or semiology, a video EEG study, structural imaging, so a brain MRI and a PET scan, and then neuropsychological testing, and sometimes more exotic testing as well. But each of these gives us a clue about where seizures are starting. And sometimes we have a really nice situation where, all of the clues line up and we have a single culprit that is concordant from all of our testing. But often we have a situation like this where, the neuropsychological testing suggests one area, the EEG another. And so the question is, how do we interpret this and what do we do from there? So that's where something called phase 2 monitoring, or sometimes it's referred to as invasive monitoring, comes into play. This is a study that's similar to a video EEG study, but instead of having the electrodes on the skin, on the scalp, we actually put them on the surface or inside the brain. Now, historically, and as recently as 10 years ago, 10 or 13 years ago, I guess, the way that we did this was almost exclusively with what are called grids and strips. So these plastic things or silicone structures we put on the surface of the brain in an array to try to monitor brain activity. But there were limitations of this. So, that's a 2D grid that we're putting on the surface of the brain. The brain is obviously a very 3D structure. Sometimes the thing that we're trying to monitor is deep within the brain, inside the substance of the brain. And so putting something on the surface of the brain is maybe not so different from putting something on the scalp. And so there were limitations of grids and strips. It's also a very invasive surgery. This is what a craniotomy for grids and strips looks like. Keep in mind that this is a diagnostic procedure, not a therapeutic procedure. The trend these days is, of course, towards minimally invasive procedures. I would call this maximally invasive neurosurgery. And so the question that these techniques have left us with is, can we be more precise and less invasive with how we do this? And so with regard to diagnostics, I wanted to talk about a couple therapies that are now very common. The first is called stereotactic EEG, or SEEG for short. This is a technique that allows us to study seizure networks in the brain with millimeter precision without needing to perform a large craniotomy or opening of the head. The procedure consists of putting these tiny wires in the brain. They're about a millimeter and a half wide. And we drill tiny little holes in the skull, about 2 millimeters wide. And we can monitor, as you can see on this X-ray, this is not very typical, but we can get to just about any part of the brain in a fairly non-invasive way. This was originally designed in France in like the 50s or 60s, but wasn't widely adopted until recently. I think this is a great photo. It's a very French thing. The guy's smoking a cigarette during his monitoring. But things have come a long way since then, and we now use a surgical robot to implant these. We have 3D planning software that allows us to do it very precisely. You compare this to the slide we saw a few slides ago, the image we saw a few slides ago. You often don't even need to shave the patient's hair. These are tiny little incisions, and then they just get pulled out in a very brief procedure. This is a CT scan from one of my patients. I think it'll play, but gives you an idea of what these electrodes look like. They have tiny little metal contacts along them that allow us to monitor different sites in the brain. And we may put 5 or 7 or 8 of these and really allow us to monitor a huge segment of the brain. Advantages of this procedure versus what we discussed before: it's safe, and I'll show you some data on that. It's at least as effective as the procedures that came before it. Patients obviously prefer it when you consider the difference in invasiveness. And it's really changing the way we understand epilepsy. We've learned a lot about seizure networks that we couldn't understand when we were just monitoring the surface of the brain. We've learned, for example, that temporal lobe epilepsy is not just one thing. There's lots of different subtypes of it. And that really allows us to customize surgery for patients. This is very effective at teaching us where seizures are coming from. This is the biggest case series I could find. A couple hundred patients, 97% of them were localized with this procedure. So very effective. And it's safe. It sounds a little scary to be penetrating the brain with electrodes, but the hemorrhage rate, the rate of serious complications is quite low. And it compares very favorably, actually, to the complication rate of the procedure I mentioned before, grids and strips. It's accurate. As I mentioned, I use a surgical robot to implant these. And so, the accuracy of the electrodes is often less than 1 millimeter. And again, if you were a patient, it's not hard to decide which of those 2 procedures you prefer. A similar procedure that we don't use quite as often, but can be quite helpful, is something called Foramen ovale electrodes. These are electrodes that are inserted using a needle that we poke in through the cheek. They enter through a small hole at the bottom of the skull that's highlighted here in green. It's called the foramen ovale. And it turns out if you insert an electrode through that, it ends up kind of near the medial part of the temporal lobe, which is a frequent site for seizures in both adults and children. So we have several helpful uses for this. We published on this, actually it's been a while now, but for patients that had this monitoring technique, we were able to glean surgically actionable information in something like 90% of patients. So it can be quite helpful and very non-invasive. Just a few slides about how we do this. The foramen ovale is this little light spot that you see here. We use a needle to cannulate that, and then we can slip these electrodes in. Here are the electrodes right here. And it turns out they sit near the medial temporal lobe. And so it's a really helpful technique, especially for a patient that's just having a scalp study, to try to figure out if they're having seizures from one or both temporal lobes. But I think the more interesting part of this talk is what I'm going to focus on now, and that's kind of what are the latest and greatest tools we have for treating these patients, not just diagnosing them. So, a while ago, this is what our surgical workflow looked like. We talked about the question of resectability. So if we find a spot in the brain that seems to be the source for seizures, if we determine that it's safe to damage or remove it, what are our options? And for a long time, we really only had one, and that was craniotomy. One common example of that was, of course, a temporal lobectomy. This is a temporal lobectomy that I did a year or two ago, where we take out a large piece of the temporal lobe. You can see the cavity here. I think it's even easier to see on the axial. Here's the other temporal lobe. And this is a great procedure. It's quite effective, but it's largely been replaced these days because we know that doing this kind of procedure has a huge impact on a patient's life. And we call this in the field neuropsychological morbidity. If you cognitively test a patient before and after the surgery, you can often see a dramatic difference, and it's usually not for the better. These are different neuropsychological metrics that declined in patients, mostly declined. You can see a couple patients improve, but declined after temporal lobectomy, and often substantially so. And we learned in the 1940s and 50s that you can't do this to patients. So this is a patient that had seizures coming from both temporal lobes. It's a very famous patient in neuroscience that is just referred to by his initials, HM. I think he died a few years ago. But this patient had a bilateral temporal lobectomy. You can see the two areas of resection here. And this patient ended up with a terrible memory deficit that's really famous. This patient could remember things that happened prior to his surgeries, but not after. He could not basically form new memories. So I don't know if anyone's seen this movie, Memento. It's kind of old at this point, but this is essentially what happens to the main character. He has a brain injury and can't form new memories, and it's quite a devastating thing. And even though this is not the case with unilateral temporal lobectomies, when we do it on one side, it does affect patients. And so we're trying to move a little bit away from this. This is also, a tool. It's a hammer. And, as someone who wields a hammer, we look for nails, but not everybody needs a resection of their entire temporal lobe. Like I said, SEEG is teaching us how to customize surgery for patients. And we've learned that the whole temporal lobe is usually not the culprit in most patients, and we can really customize what we remove or what we ablate. And so to that point, we have a technique that's gained popularity over the last decade and is now very much the standard of care across the country, and it's something called laser interstitial thermal therapy, or LIT. Sometimes it's called laser ablation. And this has really emerged as a popular alternative to opening the skull and removing brain tissue. So this is a minimally invasive technique in which we don't take the tissue out, we actually thermally damage it or burn it by heating up the tip of a laser. This is a nice complement to SEEG, as we'll see. There's a couple of commercial systems that we can use to do this. And this is what the system looks like. So there's a tiny fiber, obviously not very wide. The tip of it heats up because there's a laser here. And we anchor it in the skull using this bolt, which helps us aim where we're trying to direct the heat. And so this is what the procedure looks like when we're doing it. You can see the laser fiber entering from the back of the head here. This is a case where we're targeting the hippocampus. And this is done in an MRI scanner with the patient asleep. And we can actually see the temperature change in the tissue as we turn on the laser. And it allows us to estimate how much of the tissue we've damaged. This is a little bit more of the workflow. So this is a patient has the laser fiber in. We finished putting that in. We move the patient to the MRI scanner, and in the MRI scanner, we can use it to burn the tissue that you see here. This orange blob is the kind of damage estimate of the laser. And really, this is now a very popular alternative to a temporal lobectomy. Most patients who are getting temporal lobectomies have an onset zone in the hippocampus or the amygdala. And so we can insert the laser fiber just into that part of the temporal lobe and spare the rest of it. And I think I have a little video of what this looks like. So here's the laser fiber. This is the back of the patient's head. Here's the eyeball. Here's the nose. So this is the front of the head. And as I turn on the video, you'll see these little orange blobs. These represent areas that we have heated up and we can estimate have been irreversibly damaged from the laser. And so we start just at the tip. And then as this procedure progresses, I'll pull back the tip a little bit because the hippocampus is kind of shaped like a barrel or a cylinder. And we try to insert the laser right down the barrel of the cylinder. Here's an example case. This is a young man who'd had epilepsy actually for quite some time, 14 years. Complex partial seizures that were temporal in flavor. He had a fairly normal brain MRI, as many patients with epilepsy do, but we had captured numerous seizures from his right temporal lobe on a scalp EEG. He underwent SEEG, and indeed we confirmed his seizures were coming from the hippocampus. We did a laser ablation. You can see the little area of ablation right here, or on the sagittal image, you can see it here. And this patient had this a few years ago and has been seizure-free since that time. Wonderful, nice guy, and his life has been totally changed. Why would we do this over a temporal lobectomy? Temporal lobectomy is something that's been around for a long time. We know it's effective. We have a randomized controlled trial in the New England Journal. Here's the slide that really demonstrates that. So this is the data I showed you before showing neuropsychological declines in patients who've had a temporal lobectomy. You can see that the scores almost universally drop after surgery. With a laser, we see that scores are either relatively flat or they actually improve. So there seems to be sparing of cognitive decline that we sometimes see when we remove a large part of the brain. And this is true whether we do it on the right side, the non-dominant hemisphere, or on the left side. And of course, patients, unsurprisingly prefer this. I mean, this is a tiny incision that we closed with just a single stitch. The patients go home the next day, and there's no big incision that has to heal. And if patients' seizures recur, we can either repeat this or we can convert it to a bigger procedure if they need. But what's a catch? I mean, there's got to be a catch. Nothing's perfect. The catch is really that patients who have a laser ablation typically have a slightly lower rate of seizure freedom than those who have a big resection, for example, a temporal lobectomy. We think that difference is probably on the order of 10 or 15%. So not a huge difference. And if I were a patient, I would still choose a laser over a lobectomy, but there is a slightly lower chance of achieving seizure freedom. And it makes sense because, in the case of temporal lobe onset, we're just taking out less temporal lobe than we would if we open the skull. Again, we're usually targeting this structure here, the hippocampus, and not removing all this other stuff that we might in a temporal lobectomy. So as I mentioned, this procedure can be repeated if patients need it. This is a patient I treated years ago in fellowship, I think, but somebody who'd had right mesial temporal lobe epilepsy, had an ablation, her seizures came back, and it turned out there was just a little bit of tissue that was left over, and we repeat lasered her, and she's been seizure-free. I actually have this procedure coming up on a patient here in a little bit. And we can use it elsewhere. I've been showing you images of the temporal lobe, but this is a versatile tool. We can use the laser to reach almost anywhere in the brain. It's really established as an excellent treatment for hypothalamic hamartomas, a disease mostly in the pediatric population, but we'll see in adults occasionally. The open surgery to treat this is quite morbid. It has serious consequences, typically endocrine consequences, other side effects. Laser is an excellent tool that's fairly non-invasive and has a very favorable side effect profile for these patients. Here's a case where we used it in the insula for an insular onset. An insular resection is a challenging procedure, but with a laser, these patients can be treated very effectively and safely. And we can use it for other things too. So this is a cavernous malformation in the brain, in the tail of the hippocampus that was causing seizures in a patient. This is a vascular lesion, so you might wonder if it's safe or advisable to poke a vascular lesion with a laser. Turns out it's actually quite safe, and patients can have excellent outcomes, seizure outcomes when treated this way. So, we've talked a bit about what do we do if the site in the brain that we think is causing the seizures is safe to remove or burn. What if it's not? Or what if there's more than one spot in the brain that we think is responsible? And that's where I think a lot of the innovation is happening right now. And so one technique that we've had for a long time, I won't dwell on it too much, is vagus nerve stimulation, or VNS. This is a procedure that's been around for quite some time. It consists of a small pacemaker that we put in the left chest and connect to a wire that we insert into the neck. This works for all seizure types and is an outpatient procedure, so that's appealing to some patients. Here's what a VNS implant looks like. So here I've exposed the vagus nerve. It's a little hard to tell maybe with the screen, but it's the white structure here in the center. It's just next to the jugular vein and the carotid artery, and this battery, as you can see, is quite small. VNS has 3 therapy modes. So by default, the device goes off every few minutes, and the epileptologist kind of determines the timing of that. It also has what's called an auto-stim feature, which detects changes in heart rate that might signal the onset of a seizure. A majority, I don't know the exact percentage, but a majority of patients have a sudden increase in heart rate at the start of a seizure that appears to be different than what we see if a patient were exercising or exerting himself or herself. And so the device can detect that and deliver an extra dose of therapy automatically. And there's also a magnet that patients or their caregivers can wear on the wrist and swipe over the device to deliver an extra dose of therapy if a seizure is being observed or is expected. As with all the devices we'll discuss, the effectiveness of the therapy appears to improve over time. Not so sure I agree with that percentage, but patients who get this device, studies have shown that they describe an improved quality of life, and studies have documented a reduced risk of sudden death from epilepsy with this implant. So I think a little more of the innovation is happening with some of the other things I'm going to describe. The first is called RNS, or responsive neurostimulation. This is often referred to by the trade name or the brand name, which is NeuroPace. So that may sound familiar to many folks here. This is a device that we've actually had FDA approved for about a decade now. And it was approved initially for focal epilepsy, but we're now starting to venture out into generalized cases, as I'll show you in a minute. But the device consists of a little microprocessor that's a couple inches long that we embed in the skull and connect to one or two wires that we insert into the brain. And the idea is that this system constantly listens to the electrical activity of the brain. It's performing continuous electrocorticography. And when there is activity that's detected that is suspicious for a seizure, the device automatically recognizes that and delivers a dose of stimulation to try to stop it. So it's pretty cool. It works on its own in the background. Patients need to come in for periodic programming visits to kind of fine-tune the parameters for detection of seizures. But patients are not aware that this is detecting, and they're not aware that it's delivering therapy. I've seen patients that get thousands of therapies, deliveries of pulses a day and don't realize it. And so it's a very cool technique. Here's kind of a schematic illustrating that. So the device is monitoring brain activity. At the start of a seizure, brain activity starts to change in a way that the device can recognize. And it recognizes this because these wires are close to where we think the seizures are originating. It delivers a dose of electrical stimulation, again, that's not perceptible to the patient. And then the idea is that after that, they're calling them brain waves, but the electrocorticography returns to normal and the seizure stops. That's the idea, at least. This is what an implant looks like. This is a common, one of the most common configurations eye implant, which is these electrodes are in the hippocampus on both sides. So this is a patient that has bilateral temporal lobe epilepsy. And you can see the battery is embedded inside the skull. So we actually remove a small piece of the skull and replace it with the battery so that you can't feel it on the surface of the skin. And studies suggest that this really works. So patients, as with VNS that we saw before, seem to get better over time, the longer they have this device in. And we think that on average, patients have something like a 75–80% seizure reduction long term. It seems to work pretty much wherever in the brain we put it. This is a striking difference from what we saw with resection or ablation. So patients who get RNS, studies have confirmed, multiple studies have confirmed that numerous measures of cognitive function actually seem to improve over time. And the interesting thing is this effect seems to be independent of how much patients' seizures are reduced. And so it seems like the brain stimulation is doing something that helps with cognition, but we don't know exactly what it is. Having chronic electrocorticography, in other words, chronic electrical monitoring of the brain, can also teach us other things about patients' epilepsy. So this is a study that looked at 80 patients or so that were implanted with RNS and were thought to have bilateral temporal seizures, but ultimately, 1 in 6 of those patients was found to have seizures that were only on one side. And so that's very helpful to know. Some of those patients might be candidates for other curative therapy based on this information. It also is very helpful to epileptologists. So this is from a paper that was looking at the number of events before and after the introduction or change in the dose of a medicine. And so doctors are now able to use this data in an objective, concrete way to understand whether changes in patients' seizure medications are actually helping their seizures or not. I think, as we all recognize, it can be sometimes difficult for patients to recognize exactly how many events they're having. And this gives us a nice objective measure. RNS has also taught us that, something we long suspected, which is that patients have periods related to their seizures. So some patients will have seizures every week or so, sometimes every 2 weeks. And so we're learning new things about the brain and about seizure networks by having this device in patients. I think the frontier and something very exciting is what we call thalamic RNS. So putting this device, these electrodes, in a deep part of the brain called the thalamus rather than the cortex, which is what we typically think of as seizures starting. And this is really nice as a technique for treating patients with onset that's difficult to localize. It seems to be coming from a large swath of the brain, or even patients that are generalized. And I'll say that this is off-label, but this is something that my center is doing now and centers across the country. In particular, for patients with generalized epilepsy, we're implanting something called the centromedian nucleus, or the CM nucleus. This is a really nice scan that I was able to highlight what the CM nucleus is. It sits between the pulvinar, which is kind of the back part of the thalamus, and the mediodorsal nucleus. And you can see this on an MRI, and we can target it. So here's a couple of implants I've done for patients with generalized epilepsy. Again, this is off-label, but we have preliminary clinical studies that suggest that many of these patients do better even than the partial onset patients. And there's now, up and running a randomized controlled trial looking at this. So stay tuned. The hope is that within a few years, this might be FDA approved. Another new technique, something I do almost several times a week for patients with other disorders, but we also have now as a tool for epilepsy, is deep brain stimulation, or DBS. So DBS is similar to RNS. We put 2 electrodes into the brain, but we target a different area of the brain than we do for patients with essential tremor or Parkinson's disease or dystonia, some of the other things I treat. This was approved by the FDA for epilepsy in 2018, so we've had it, for almost 5 years. Unlike RNS, the implant is stereotyped from one patient to the next. We target the same part of the brain, and it's called the anterior nucleus of the thalamus, or ANT. This does not require us to do the invasive monitoring that we talked about earlier, SEEG or the like. And we have a randomized controlled trial that showed that this helped patients. And then we've had better studies that have followed these patients for longer afterwards that appear to show long-term, we see a very similar amount of seizure reduction, on the order of 70 to 80% for patients that are treated with DBS. These patients also report a reduction in seizure severity, improvements in quality of life, and some neuropsychological measures actually also improve with DBS like they do with RNS. There are some exceptions to this. Patients in the pivotal clinical trial that led to the approval of DBS, some of them reported problems with memory. A lot of those weren't borne out on formal neuropsychological testing, but I am careful with this procedure for patients that either have a significant pre-existing history of depression, because that can also worsen, or a perceived or documented severe problem with memory. Here's the target. So this kind of little blue dot here, the red dot, is something called the mammillothalamic tract, which is something we're able to see on MRIs. But generally, we're aiming to put the electrode more or less right there. So, this is where we were in 2010. Our surgical algorithm, in most cases, there were some other exotic procedures, but this was kind of the mainstay of what we did. And, here in 2023, just a little over a decade later, things are considerably different. I expect it's going to be considerably different another decade from now. I'll point out that for many patients, we're skipping some of this invasive monitoring, and this was the Monopoly card. That might be hard to tell from here, but instead of going directly to jail, we're going directly to neuromodulation, and we're not often bothering with invasive monitoring for patients, because we're learning a lot about how these neuromodulation techniques work, how effective they are, what their limitations are. And we're really trying to avoid more and more invasive procedures for patients. So I think it's a really exciting time in epilepsy surgery. I'll make a quick plug for my website. I think we have the URL on a few of these slides, but I have pages on epilepsy. I have pages on all the procedures we discussed today. And so it's intended to be presented in a patient-friendly manner so patients and their families can read about some of this stuff. But with that, I'll wrap up and thank you guys and leave some time if anyone has questions. Yeah.
I do have a question with the RNS.
Mhm.
You know, if for some reason it doesn't work or the patient isn't happy with it, what do you do to kind of fill the whole battery?
Yeah, so, you know, the good news is that the number of patients who don't see a meaningful change is fortunately quite low. But if it does need to be removed for whatever reason, I mean, another reason, probably the most common reason we have to remove it is infection. You know, our infection rate is less than 1%, but that's still patients who get infections and might need it removed. So that gap can be filled with a synthetic cranioplasty, synthetic bone that we get 3D printed based on a patient's CAT scan. And so that's a fairly small and straightforward procedure that can be done. You know, we have to do it very commonly for patients that have big craniectomies if they have a stroke or you know, other brain hemorrhage, brain injury that we have to take a piece of the bone off. And so we just do the same thing there. But in this case, it's just a tiny little cranioplasty. Yes?
Regarding the BNS,
Mhm.
there are 3 modes that it can go to.
Yeah.
Can you set it up for all 3, or is it you can only have pick one of those 3?
So the new device that we put in has all 3. You don't have to pick and choose. It has all of them. United Healthcare has decided that they don't want to cover that for patients. And so United Healthcare patients can't get it, but every other patient can get it. But the new device, the modern device that we implant, even if we're replacing an old battery, we put in the new one that has all 3 of these features, yes.
How often do they need to be replaced?
It depends on how much kind of current, what the settings are on the device, so how much juice it's pulling, so to speak. So I would say on average, patients are something like 7 or 8 years, but it can be a little less, can be more. Yes.
Other than CPS having depression, do you see worsening psychiatric outcomes in any of the other?
No, not really. So RNS pretty much across the board, all of those measures improve. It's not to say that there couldn't be some patient that has challenges with an implant, but it's not a described phenomenon. We think that the anterior nucleus of the thalamus is just in a different circuit, and it is more tightly connected to the emotional circuit than say where we typically implant RNS. But the other procedures we do not think really have meaningful impacts on psychiatric conditions, no. We like to see that patients, if they do have pre-existing psychiatric conditions, are pretty optimized coming into surgery so that if they were, you know, to struggle after surgery, that they have a resource to try to deal with it. But it's not an expectation. We don't have good studies that suggest that patients have problems with those other procedures, no. So I think they're going to be touching on that in probably a different session. You know, I think there's increasing evidence for CBD, you know, and there's of course a commercial product for treating epilepsy. As a surgeon, I don't deal so much with the medical side of things. And so you know, there are people far smarter about that than I am here. So you'll be hearing from them on that topic. Yes.
Sorry, at the beginning of the year,
1 in 20, I think that's the statistic, right? 1 in 26 people at some point in their lifetime will have not a seizure, but will have epilepsy. And so, you know, for some of those patients, it doesn't become a lifelong problem, or they find control with medications, but epilepsy is actually a fairly common disorder. Yeah. I don't know if I have a statistic on that. Maybe I didn't, but yeah. Huge unmet need. I won't go through all the slides to try to find it, but yeah. Yeah. Mhm. So, yeah, I'm not so up to date on that, but I know that people were looking at either gene therapy or stem cell therapy in the hippocampus. And there may be ongoing clinical trials on that. I think it's probably a ways away from being in clinical use, but I know people are looking at that, yes. Okay, well, thank you guys very much.